Prasad, MBBS, MS General Surgery, FIAGS. I'm senior resident. So far, I have 10 publications in my credit. I am also the BCLS instructor in Sree Balaji Medical College. Today, we are going to study on developmental anomalies of face. So first, let us learn about the development of face. Face develops from the median nasal process along with the fusion with lateral nasal process, maxillary process, mandibular arch, globular arch, olfactory pit and the eye itself. Fusion between these is normal in the intrauterine life. Any change in the development or the fusion of these arches lead to formation of different types of cleft lip and cleft palate, both complete and incomplete. Let us see the causes for cleft lip and cleft palate. Familial causes, protein and vitamin deficiency, rubella infection very commonly seen in India and other developmental countries, radiation anomalies, chromosomal abnormalities, maternal epilepsy, drug intake during pregnancy that can cause phocomelia. Steroids, eptoin, diazepam have been proved to cause developmental anomalies in face in children. Let us see the classification of cleft lip and cleft palate. Cleft lip alone can be classified into unilateral and bilateral along with median. Cleft lip alone is classified into unilateral or bilateral or just in the median. Classification of cleft lip and cleft palate. Cleft lip alone is unilateral, bilateral or median. Cleft of the primary palate in the front of incisive foramen only. It could be complete or incomplete. Complete means absence of premaxillary process. Incomplete means rudimentary premaxillary process. They can be one of the three types: unilateral, bilateral or median. Cleft of the secondary palate behind the incisive foramen. It can be complete, incomplete or only the submucous. Complete means nasal septum and vomer are separated from the palatine process. Incomplete is partial fusion. Submucous is with or without soft palate involvement. Cleft of both primary and secondary palates, and cleft lip and palate together in any combination. Let us start on cleft lip. It can be central, which is rare and present in the upper lip between the two median nasal process. Lateral, it is the commonest. It can be either unilateral or bilateral between the maxillary and the median process, either on one side or both the side. Incomplete cleft lip does not extend into the nose, but complete cleft lip can extend into the nose and the floor of the nasal floor. Simple cleft lip is only cleft of the lip is there. Compound cleft lip is a combination of cleft lip with cleft. Simple cleft lip means only there is cleft of the lip. Compound cleft lip means there is cleft lip with the cleft of the alveolus. Incidence, it is commonest in Caucasians. Incidence is 1 in every 600 live births, much more commonly seen in male than in female. 75% of these cleft lip is seen unilaterally, and among them 60% are seen on the left side. 50% of the cases are combined with cleft lip and cleft palate. 15 to 25% of these cases have cleft lip alone. About 25 to 40% have cleft palate alone. What are the complications that are associated with cleft lip and cleft palate? We will see. These are commonly seen in children in young age as congenital anomalies. So right from starting after the birth, the complications arise. There will be difficulty in suckling and swallowing reflex, and they are much more common in cleft palate. Defective speech is much more common in cleft lip. Altered dentition and supernumerary teeth can also be seen. Recurrent upper respiratory tract infections, respiratory obstructions, middle ear problems can be seen. Cosmetic problems is much more alarming. Hypoplasia of the maxilla problems and associated due to any of these complications can be seen in cleft lip and cleft palate. Let us see on the management of cleft lip. Millard criteria is used to assess whether the child can be taken up for surgery or not. The criteria involves 3 points. The baby has to be 10 pounds in weight. it has to be at least 10 weeks old after birth, and the hemoglobin should be at least 10 gram percentage. In Millard cleft lip repair, we have to rotate the local nasolabial flaps. Management of associated primary and secondary cleft palate deformity should also be done. Proper post-operative management like control of infection should be done. Later on, training for suckling and swallowing along with speech therapy should be given. Apart from Millard cleft lip repair, we can also do Tennyson's Z-plasty, which releases the tension in the cleft lip. The main principle we have to note in cleft lip repair are rule of 10 should be fulfilled. Before 6 months of age, it has to be operated. That is, before permanent teeth arise. Principles of cleft lip repair. These are the points that should be fulfilled when a repair has to be done. The rule of 10 should be fulfilled. Before 6 months of age, it should be operated when all the temporary teeth arise. There should be no pre-existing infection. Millard advancement flap should be done, or Tennyson's Z-plasty can be done. Bilateral cleft lip repair can be done either in single stage or multi-stage. Most commonly, 2 stages done with 6 months gap in between. One stage bilateral cleft lip repair is done using View 3 method or Millard's single stage or black method. 3-layer lip repair should be done where mucosa, muscle and the skin, all three should be sutured separately. The cupid's bow should be horizontal and the continuity of the white line should be maintained. Mistakes in these will form deformities or asymmetry between the left and right side. Let us start on cleft palate. This is due to the failure of fusion of the tube palatine process and a defect in fusion of lines between the premaxilla and palatine process of maxilla on each side. When premaxilla and both the palatine process do not fuse, it leads into complete lift. It is type 1. Incomplete fusion of these three components can cause incomplete cleft palate beginning from the uvula towards posteriorly at various lengths. Based on the invasion inside the soft palate, we divide it into 3 types in type 2A, type 2B and type 2C. Type 2A is the uvula itself is bifid. In type 2B, there is soft palate in its entire length. In type 2C, both the soft palate and the posterior portion of the hard palate, but the anterior part of the hard palate is normal. Small maxilla with crowded teeth, absent or poorly developed dentition, URIs with a recurrent infection is common, chronic otitis media with deafness when middle ear bones are involved, swallowing difficulty to certain extent and speech problem along with cosmetic problems. The management involves the same Millard's rule of 10 kg body weight, 10 months of age, 10% of hemoglobin should be seen. The cleft palate is usually repaired at 12 to 18 months of age because early repair can cause retarded maxillary process growth. Late repair causes speech defect. Both the soft and hard palates have to be repaired. Abnormal insertion of the tensor palati has to be released. If maxillary hypoplasia is present, then osteotomy of the maxilla is done with orthodontic help for dental extraction and alignment of the dentition. Regular ENT examination for speech therapy should also be given. Complicated cases, better to do multi-stage procedure than single-stage procedure. Vardy's Kilner's pushback operation is commonly done. Apart from surgery, secondary management needed are hearing support when middle ear involvement is present, control of otitis media, speech therapy along with pharyngoplasty, veloplasty and speech devices. Dental problem like uneruption, unalignment are common and have to be corrected with a dentist and a reconstructive surgery. Orthodontic management with alveolar bone growth, maxillary osteotomy can be done. This is done later on at 8 to 11 years of age. Dental implants, rhinoplasty, orthognathic procedures also be done that involves jaws. Principles of palatoplasty. It is done at the age of 10 to 18 months. Here mucoperiosteal flap is raised. Palatal defect is closed using 3 layers, the nasal, mucosal and oral layers. The hook of the pterygoid hamulus is fractured to release the tensor palate muscle to relieve any tension in the suture line. With this, we will conclude this class. Thank you.